Sujit, Dr. Sujit, sir, we can start the presentation, sir.
Yeah, I would say yes. If the teachers have joined, please start. It's already 7:40.
Okay, sir.
Those who are not presenting can mute their mic so that there is no disturbance during the presentation. Yeah.
Hello,
Yes, sir.
this is Dr. Prabhakar. Sorry for joining late.
Sir, good evening, sir.
Good evening.
If you are ready, we can start, sir.
Yeah.
Okay. Thank you, sir.
Thank
Good evening, respected teachers and dear colleagues. So I'm first presenting the long case. 59-year-old female, homemaker from Palladam, presented chief complaints of lump in right breast for last 4 months. She was apparently normal till 4 months back when she noticed a small swelling in the inner aspect of the right breast. She gradually increased in size over last 4 months to attain the present size. There is no history of any pain or trauma associated with the swelling, no history of any discoloration or ulceration of overlying skin, no history of any nipple retraction or nipple discharge, no history of any swellings in the right axilla, opposite breast axilla or neck region, no history of any fever, night sweats, loss of weight or loss of appetite, no history of any generalized body pain, no history of any abdominal distension, jaundice, no history of any dry cough, dyspnea on exertion, no history of headache and vomiting. Past history, there is no history of any biopsies or surgeries in the breast in the past. She's a non-hypertensive for 15 years on antihypertensives. She's a non-hypothyroid on thyroxine for the last 15 years. No history of any diabetes, bronchial asthma, or coronary artery disease. Menstrual and obstetric history, she attained menarche at the age of 14 years, regular cycles, married at the age of 24 years, first childbirth at 25 years, and second childbirth at 28 years. No history of any miscarriages or no history of any combined oral contraceptive use. She breastfed for a total of 3 years. She attained menopause 6 years back. There is no history of any hormone replacement therapy. Personal history, normal sleep and appetite and consumes mixed diet, normal bowel and bladder habits. Family history, there is family history of breast cancer for mother at the age of 60 years and underwent surgery and died within 1 year of diagnosis. There is no other details regarding the regarding any histopathology or anything is available with the patient. No history of any other malignancies in the family. Treatment history for the above complaints, patient was evaluated at a local hospital and underwent a biopsy and referred to our hospital. So, summary of the history, it's a 59-year-old postmenopausal lady with comorbidities of hypertension and hypothyroidism with family history of breast cancer and first degree relative with a presenting complaint of right breast lump of 4 months duration. Should I go to the general examination? Sir? Sir,
You go to the previous slide. With the history, what do you think?
sir, it's a postmenopausal lady with a family history of breast cancer. So my first PD will be malignancy of the breast.
Okay, no. How can you be so sure? Because family history alone cannot be a I mean, see a breast as the first diagnosis, no?
Sir, also the duration of the history is 4 months, and also in 50% of the patients, age and gender alone will be the risk factors. So she's 59-year-old,
Mhm.
and also the short duration of history, 4 months history of breast lump. And that is the incidence wise, that is the most common malignancy in a female.
So when you think
So
of
with this,
malignancy of different, why not the other benign conditions or any other
sir, I will keep,
conditions? Why you talk about breast, see a breast upfront?
sir, the benign, I will keep the benign breast TDs in the like downside, because the age is not predictive of a benign breast disease. Usually occurs in younger age group.
You also want to ask question?
No. No, do you think the family history of this patient is more relevant, particular to this patient?
So it's a family history, first degree relatives, but the age of the age of occurrence of the breast cancer in the first degree relative was at the age of 60 years.
Yeah.
So it will.
Do you think this has a strong correlation, or
It has
other age group people you can consider as a strong correlation with
it's a weak
this
correlation,
cancer?
sir. If the age of onset
So
was
in,
less than 50
yeah.
years, it should have been a good
Yeah,
strong
so it
correlation.
is, yes, very good. It is less than 50 years, we can think of strong correlation with the family history.
Yes, sir.
Yeah, okay.
What other features you will think of a strong family history?
Sir, if the patient's age was less than family histories. Can
Yeah,
you repeat the
family
question?
history.
Sir, if it is a
What are the features to say it's a strong family history?
okay, sir. So any other family first or second degree relative with any other malignancies like ovarian, pancreas, prostate, endometrium, or or a male breast cancer in the family.
Yeah.
Yeah.
Bilateral breast cancer.
Bilateral breast cancer.
Yes.
Any history of metachronous breast, like patient has any history of previous malignancy.
What are the patient per se oriented history which suggestive of familial breast cancer? Apart from the families, what are the features which can be seen in that particular person?
So from the history or as in general, sir?
From
So
the
in
history.
general, if it is from the pathology, if it is a triple negative breast cancer or
Breast cancer, do you think it's familial?
so if it is a triple negative breast cancer, there's more chance of
No, you said the first
positivity.
relatives, you said about the age. So what are the factors in that particular patient itself that may suggest of it's a familial?
So if there is any histology wise, if there is any LC lobular histology or
No, before in history itself.
history
Sir,
itself.
I mean, hormones are also asked the same, no? He gave one clue.
Sorry, sir, I didn't get that.
It's bilateral.
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 And then what else? Personal history of?
So personal history of any ovary or endometrium,
Ah.
or personal history of any gastric cancer.
Mm.
That is suggestive of that will increase the risk.
If you have breast cancer, the other BRCA cancer also you can tell about the gastric cancer, colon cancer, pancreas,
And yes,
and endometrium also.
yes.
Okay. Okay. Anyone else want to ask any other questions? Shall we proceed? Or?
Yeah, we can proceed.
Oh, yeah. Okay. Proceed, Priyanka.
So general examination, ECG performance status 1, conscious, cooperative, or oriented to time, place, and person. Height 150 centimeter, weight 54 kg, BSA 1.5, BMI 24, no pallor, icterus, cyanosis, clubbing, pedal edema, skin and thyroid normal, pulse rate 84 per minute, blood pressure 130/80, respiratory rate 18 per minute, and she's febrile. Coming to local examination, she was examined after ensuring adequate privacy, exposing up to the waist, and she was examined in the sitting position, recumbent and semi-recumbent position. An inspection examined in the sitting position, hands by side, hands above head, and hands on the hip, pressing and releasing. And on inspection, the both breast appears at the same level, and there is a mild fullness noted in the right upper inner quadrant, and there is a scar of size 0.5 centimeters seen over the fullness. There is no skin dimpling or puckering. There are no engorged veins, no ulceration, pude, orange, or cutaneous nodules. Both nipples are at the same level, and no nipple retractions or nipple discharge. Nipple areolar complex normal. No visible swelling in the right axilla, right supraclavicular region, or right arm. No visible swelling in the opposite breast, axilla, and supraclavicular region. Palpation, 4 into 4 centimeter heart mass palpated in the right upper quadrant, extending from the 12 to 2 o'clock position, irregular margins and surface, hard in consistency. There is no local rise of temperature or tenderness. The mass was fixed to the breast tissue. There was no fixity to the pectoralis major or chest wall. There was no skin involvement. In palpation of right axilla, there is a 2 into 2 centimeter mass, which was mobile and non-matted and hard in consistency, was palpated in the level 1 region in the pectoral group. Palpation of right supraclavicular fossa, no palpable knots. Examination of right arm, no lymphedema. Palpation of left breast axilla and left supraclavicular region, no lump palpable. And systemic examination was examination of cardiovascular system, respiratory system, abdomen, and central nervous system was within normal limits. And examination of the skeletal system, no bony tenderness, skull and spine normal, and PV and PR couldn't be done. So from the examination, so it's a 59-year-old postmenopausal lady, hypertensive, hyperthyroid, family history of breast cancer with a hard breast lump of 4 months duration, and clinically there is a hard lump of 4 into 4 centimeter in the right breast upper inner quadrant with a 2 hard mobile right axillary node. So my probable diagnosis is a carcinoma of the right breast.
Carcinoma of the right breast, so you can tell the stage of the cancer.
TNM staging,
T2N1.
clinical T2N1.
So you have told that there is an lymph node examination shows a level 1 node. How will
Yes,
you
sir.
say it is level 1 node?
So it was palpated in the anterior against the anterior axillary fold in the pectoral regions. Right? It belonged to the pectoral group of nodes.
Will you classify the level 1, 2, 3 nodes?
So level 1 is lateral to the pectoralis minor, whichever nodes are lateral to the pectoralis minor. Level 2 is which are behind the pectoralis minor, and which are medial to the pectoralis minor are level 3. So in the level 1,
so
in
the
the level 1, it includes the pectoral group, the central, the apical, brachial, and the posterior subscapular group.
Yeah, okay. So the level of lymph node is classified into 5 groups, isn't it? Pectoral, anterior, posterior, central, apical, and lateral, isn't it? Yeah.
Yes, sir.
So these are the nodes are in the level 1.
Yes, sir.
Okay. Then, if the patient is having any skin changes in the examination,
No skin changes, sir. No ulceration, no skin satellite nodules, or no edema, purity orange appearance, sir.
so
Puncturing.
is there any fixity of something? You told that is there any fixity?
There is no only fixity to the breast tissue, sir. No fixity to pectoralis or chest walls. Pectoralis major.
How will you identify the pectoralis fixity and the chest wall fixity?
Sir, for assessing the fixity, I'll ask the patient should be in the sitting position with hands on the hip, pressing and releasing, and while the hands are in the relaxed position, I will move the lump along the along the muscle fibers and against the muscle fibers. And if the lump is mobile along the line of the muscle fibers and right angles to it, it means it is not fixed to the muscle. And while contracting the while pressing the hip, the muscle will get contracted, and then I will move again. I will check in the along the line of the muscle fibers and against the muscle fibers. And if it is fixed to the pectoralis, there will be restricted mobility along the line of the muscle fibers, and there will be movement against the muscle fibers. And if
What do you mean by
the
against the muscle fiber?
no, sorry, not
With-
against that, at right angles to the muscle fiber, along the line and at right angles to the line of the muscles.
Okay.
And if there is chest wall fixity, the lump will be have a restricted mobility irrespective of whether the muscle is relaxed or contracted.
Can you say fix it with the chest wall during inspection?
Sir, inspection, if we can ask the patient bending forward position, if the one breast fail to fall forward, considering the other breast, we can say
Asymmetry in the falling of the breast, you can suspect chest wall.
yes.
And you said there's a fix it within the breast tissue. How will you test for the fixity within the breast?
For testing the breast fixity, I'll first stabilize the breast with one hand, and with the other hand, I'll move the breast.
Mhm.
So if it is fixed to the breast, it won't be. It is fixed to the breast tissue. It won't be mobile.
And after an examine a breast lump, systematic examination of breast lump.
So for that, we need ideally it should be conducted in the sitting position, recumbent and semi-recumbent position.
Okay.
And in the sitting position, patient should be examined with hands by the side, hands above the head, and hands on the hip, pressing and relaxing, and bending
Position
forward
and all
position.
okay. So where will you go to touch first?
So with the palm of the fingers, we have to palpate. Sir.
Okay. That's all right. So in
Palm
the
or circles.
breast, which part will you start first? Straight away you go to the side. Lump.
There are either we have to go systematically according to quadrant wise, sir.
Okay.
Starting from the upper outer quadrant, or we can go in a circumcisional way, like starting from the nipple area of complex and palpating outwards.
Go away. Okay.
Have you examined the supraclavicular fossa?
Yes, sir. Bilateral supraclavicular fossa examined, sir. No palpable nodes. Correct.
Okay.
Is there any other fixity you have to do? Chest wall, between the breast, chest wall, and pectoralis? Is there any other muscle you can see the fixity?
Sir, if it is a outer quadrant lesion, we have to see fixity to the serratus anterior muscles.
Okay. And how will you test for that?
For that, we should ask the patient to push against the wall with her outstretched hands. Sir. The muscle will be contracted, and we can see the fixity.
Sir, anything else you want, sir?
Yes, very easy to tell. That is, if during rest, if you are examining the breast mass, if it is the mobility is restricted, it is fixed to the chest wall. if there is a movement and when you are contracting the pectoralis muscle, if there is a restriction, you can say it is pectoralis muscle fixed.
Yes, sir.
Okay. So, what is there any difference in this means chest wall fixity and pectoralis muscle fixity in the management of breast cancer?
So the staging, the chest staging will change, sir. Chest wall fixation
Okay.
will upgrade the stage, sir.
Okay.
It will become
Any? Okay. Can you offer surgery for the particular patient?
sir.
Can you offer if you are giving neoadjuvant chemotherapy and downstage the tumor?
Yes, sir.
After that, can you offer surgery for this particular patient if there is a fixity to the muscle or chest wall?
Sir, after neoadjuvant, if there is
Hmm.
staging, we can offer, sir.
Offer. Then what is the surgery? You can include chest wall resection also.
Sir, radical
If it is fixed to the
muscle and ribs also, if needed, they are.
MRM, we have to go ahead with radical mastectomy.
yeah. Okay, sir. How can you proceed further?
So I will proceed with first I will go ahead with baseline blood investigations followed by investigation to confirm the diagnosis. Baseline CBC, RFT, LFT, ether and serology I'll do and go ahead with bilateral mammogram and histological for the histological diagnosis I'll go ahead with the trocar biopsy.
So which mammogram will we prefer?
Bilateral mammogram.
Which modality?
X-ray mammography, sir.
Okay. What other modalities are available?
So UST also can be done, sir. If
Okay.
but above the age of 40, we'll prefer mammogram. Only if there is a dense breast and it can't interpret the mammogram findings, ultrasound will be used to correlate the findings.
Okay. What are the other modalities?
Breast MRI.
MR mammogram is there.
MR mammogram.
When will you prefer MR mammogram?
Sir, MR mammogram, in case if we are planning for a new breast conservation surgery, we'll definitely need a MR mammogram. Also, if any findings in the mammogram, we can do a
Any particular age group you will prefer MRI over the other X-ray or?
so younger age.
No, younger
we
age.
prefer MR mammogram.
So you will prefer X-ray mammogram above which age? So what age you will prefer?
Above the age of 45, sir.
So below that we can use a MR mammogram. Okay. Is there any other modality? Is there any PET MR mammogram?
I'm not sure, sir, for that.
So, right. Okay. Have you done mammogram for this patient?
Yes, sir.
Mammogram finding.
So this is the mammograms.
Okay.
Caudal and medial lateral oblique views.
Okay.
So the lump masked with the spiculated margins. Actually, the image is not that clear.
Mass or opacity or?
So opacity with spiculated margins.
Okay.
In the inner quadrant. And in the axilla, actually, axillary nodes can be seen, sir. The exposure is not good.
What are the features you will look for in a mammogram?
So mammogram, the malignancy features are loss of the architectural distortions or a opacity with spiculated margins
Okay.
then microcalcifications,
Ah.
and
Any particular pattern of microcalcification that that is more in favor of malignancy?
sir, towards microcalcification. No, sir, fine microcalcifications.
Fine in one particular duct rather than a cluster of
Cluster classification. So, no,
When will you prefer intervention in the mammogram? So if a patient breast lump presented to you with a mammogram report, when you want to do intervention, like any FNAC or biopsy, in the which score you have to proceed?
so from Virat's 4, I will do I'll do biopsy, sir.
Okay, up to BIRAD 3, you can wait.
directly, what will you do?
Virat 3, I will advise for a repeat ultrasound after 6 months.
So what is BIRAD 6?
So Virat 6 is already like histology proven breast cancer in which we are taking a mammogram.
Yeah, okay. So this is the mammogram finding. Then how to proceed further?
So I will go ahead with a true cut biopsy from the master.
So what is the lump size?
Lump size was 4 into 4 centimeters. Sir. Mammogram wise,
This is,
clinically it was 4 into 4, sir.
oh, clinically, but mammogram size is 2 into 3
3
centimeter.
centimeters, sir.
Okay. So which would you like to prefer? Go for FNAC or biopsy?
I'll go for a true cut biopsy, sir, because I will get more tissue because I will need to do further IHC or receptor status.
Yes, alone. You have to identify the
Also, I need
type
to
also. You have to identify the
Yes,
subtype. You have to identify the grade. Then you have to
grade also,
identify the features as well as immunohistochemistry. For that, you need more tissue. Okay.
yes.
What is the
Okay,
relevance?
yeah.
Advantages of FNAC and relevance of FNAC?
FNAC,
What is the advantage of FNAC?
sir, is like the turnaround. We'll get a quick diagnosis, sir. Otherwise,
It's a simple procedure. It can be done
simple
in office
procedure.
procedure. One thing. Okay. Then
Mhm.
when will you prefer FNAC over a true biopsy?
FNAC.
When a clinical suspicion is not sure, if you are clinically not sure if it's a malignancy, so you still benign condition is a possibility. That case, you can do an FNAC as a simple office procedure.
Oh,
What is the yield with FNAC, of yield of malignancy with FNAC?
um, low yield, sir.
Oh,
Percentage.
around 70 to 70% only you can get it.
This patient is came to you with an FNAC and the biopsy report. Okay. So FNAC shows an invasive ductal carcinoma, but the biopsy is non-malignant.
Okay, sir.
You understand?
Very good.
So the
Yes.
patient visited to you with the FNAC and the biopsy, both report.
Okay,
FNAC shows the invasive ductal carcinoma, and the biopsy shows non-malignant true cut biopsy done elsewhere, which was non-malignant. How will you approach?
Then go for a guided biopsy, sir. Maybe.
So the already patient underwent guided biopsy only.
Okay, then if there is strong clinical suspicion of malignancy, I'll go ahead with an excision biopsy.
Okay. So excision biopsy, then
Excision biopsy, and I'll see.
means excision biopsy alone, or you can offer for excision biopsy during the procedure. You can offer for frozen.
So I will first do an excision biopsy to subtype side. Also, if this is a malignancy, Before proceeding with surgery, I will like to know the receptor status also, sir. So I'll first do an excision dialysis.
Yeah, okay. Okay, and then and also you can offer the frozen also.
Okay.
Frozen and the same time itself, it is almost the size of the tumor is only we need yeah, triple negative or HER2 positive, then only our treatment plan is going to change.
Yes, sir.
Okay, it's well then. Okay, proceed.
So this patient's Stukat biopsy showed invasive ductal carcinoma,
Okay.
grade 2.
Hmm.
ER positive, PR negative, and HER2 IHC 3+.
3+. What is your plan of treatment?
So it is a so I have confirmed with histology. Now I need to proceed with the staging investigation, sir.
Okay.
It's a HER2 positive disease and T2N1. So definitely the patient will need pre-op chemotherapy. So I will proceed with the staging investigation before that.
Okay, if the patient is the report says it's a HER2 2+, what will you do?
Ask for a reflex fish testing, sir.
Okay, what do you mean by low HER2 and when will you say it is a low HER2?
Sir, low HER2, it's like low HER2 is HER2 1+, sir.
Hmm.
So that is weak to moderate intensity staining. The incomplete weak to moderate staining in less than 10% of cells, sir.
Okay, which patient you offer for the fish? 1+ or 2+ or both?
Sir, 2+ only I will ask for fish, sir.
Okay.
You asked about this low HER2. One more point is there, no? Low
Sir,
HER2.
ultra low is there, sir.
No. In low HER2 also. You said only IHC 1+.
Sir, sir, IHC 1+ and 2+.
2+?
I didn't get you, sir.
Yeah, same. Yeah, correct. 2+ without?
2+ and 1+, sir.
No. You said, so Sir asked what is the low HER2?
Okay, sir.
So what are the two things are there? No, one is IHC 1+, and what is the other condition?
And
IHC 2+ and
negative fish, sir.
fish negative. Oh, yeah.
Negative fish, yes.
Fish negative. Okay. So you said something about ultra low. What is that?
So that is weak incomplete staining in less than 10% of cells, sir.
What are the stages of the
Significant in metastatic settings, sir.
Oh. Then what are the staging of the do?
As a instruction protocol, we will do a PET CT scan, sir. FDG PET CT.
If it is not
If it's
available.
not available, I'll go ahead with
If a patient is not affordable, then what will you do?
I'll go ahead with a CT chest abdomen with a bone scan or a skeletal survey, sir.
The patient is not fit, willing for CT also. What is your clinical staging?
Clinical stage is T2N1, ER positive, PR negative, HER2 positive, sir.
Okay.
So I will ideally need a CT. If the patient, but at least I will go ahead with an ultrasound and chest X-ray.
Chest X-ray.
And skeletal survey.
Skeletal survey by?
X-ray, sir.
When will do bone scan? Is this
Ideally,
offer bone scan?
Patient gives any
This clinical stage, will you offer a bone scan?
Sir, node positive and node positive disease, sir.
T3, T2N1, there's no need to go ahead with that.
Yes, more than stage 2B will be bone scans.
So when will you do bone scan? The same, T2N1.
Yes.
Will you altogether skip bone scan, or we will offer bone scan in certain patients?
So if the patient has any clinical symptoms suggest your
No.
skeletons or any
Pain or
ALP, alkaline phosphatase
is raised, then also you can offer bone scan. Okay. So what is the investigation you have done here for this patient?
So we have done a patient PET CT, sir.
Okay.
So PET CT showed the breast lesion and the axillary node, and there is a centimetric internal mammary node with significant SCV uptake. And there is no evidence of any distendments.
For the okay.
So
Why you have done PET CT for this patient?
sir, it is a T2N1 HER2 positive disease, sir. So patient will be going for neoadjuvant treatment. So before that, we need to do a staging with PET CT, sir. As institutional, we need to do an imaging imaging workup for staging. And as institutional protocol, we are doing PET CT. The patient can't afford PET CT, we will do CT, chest abdomen with skeletal survey, sir.
So is it recommended PET scan for staging workup?
So PET is recommended only in certain scenarios, like if the CT is inconclusive of like confirming certain findings.
Okay.
Or we can do as an institutional protocol, sir. Otherwise, it
This
is
is your institutional protocol. Okay.
yes, sir.
Okay.
What are the nodes involved?
So it's axillary node and internal mammary node, sir.
Okay. So what is the stage now?
So the stage will become T2N3B, sir.
Stage. Okay.
Clinical axillary and mammary, internal mammary.
Internal memory, what will be the stage?
So in the presence of axillary node, if the internal mammary is positive, it is
No, in the absence of axillary,
N2B, sir.
memory becomes? No, in the absence of axillary, internal
In the
memory
absence of that is N2B, sir.
N2?
N2B, sir. In the absence of axillary node.
So, okay. So what will you do now?
So I will proceed with investigations. These patients will need neoadjuvant chemotherapy. So I will proceed with investigations for the chemo. So I will do the blood workup and also I will get a cardiology.
There is the internal memory node is not there. It corresponds to the clinical staging of T2N1.
So even then, as it is a HER2 positive disease, I will go for neoadjuvant chemo, sir. T2N1 will come under stage 2B, sir. Composite stage 2B.
So it's which group? Early or local advanced?
Early stage disease.
So when will you offer neoadjuvant chemo for early breast cancer?
So for early breast cancer, if the receptor status is triple negative or HER2, I will offer. And also, if there is a large lump to large. So if the patient wants a BCS and there is a the lump to breast ratio
larger mass
to make it
breast.
abnormal for BCS, I will give.
Okay. What neoadjuvant will you think of? What neoadjuvant will you think for this patient?
This patient is hypertensive.
The molecular subtype is? Molecular subtype.
HER2 enriched. Sorry, luminal B. Luminal B, HER2. Luminal
PR positive, PR negative. Positive.
Sir. Luminal HER2 positive, it will come, sir.
What will be your neoadjuvant plan?
So this patient is a hypertensive for last 15 years, sir. So I will do an echo and a cardiac fitness before proceeding with chemo.
Hmm.
And I will preferably go with a neoadjuvant with which includes a anti-HER2 agent and chemo. So I'll
What exactly will you give?
So I'll go ahead with the trastuzumab, pertuzumab, carboplatin, docetaxel based chemo, sir. TCHP regimen I will go, sir. Because considering the hypertensive history, I will preferably avoid the anthracyclines for this patient.
Oh. Okay, how many cycles will you give?
So TCHP I will give 6 cycles, and then during each cycle I will clinically assess the patient for response. If there is no symptom suggestive of progression, I will complete 6 cycles and will refer the patient for surgery, sir.
Okay. So after the surgery, what will you?
What is your plan of treatment?
Plan of treatment
Neoadjuvant
followed by surgery, sir.
neoadjuvant, what
Neoadjuvant chemo
regimen?
and anti-HER2 agents, sir.
Dual or
Dual anti-HER2 with trastuzumab and pertuzumab, sir.
okay. So before doing that, you are going to check for the echo,
Echo, sir.
isn't it?
Yes,
Is
sir.
there anything other that is? Do you know about the GLS pattern? There's a global longitudinal strain of LV function. You heard about it?
Yes, sir.
Is there any significance over echo?
Sir,
Conventional echo, or you can look at the GLS.
yes, sir. So
You can prefer to go with better. You can
Yes.
go with dual blockade. Better you can go with GLS,
Okay, sir.
and it may be assess the early chance of involvement of myocardium.
Okay, sir.
Okay, so your preference of choice is TCH with P.
Yes, sir.
Okay. This is the dose you like to give with pertuzumab.
So, chemotherapy,
No,
paclitaxel.
please just tell pertuzumab. We asked for pertuzumab.
Sorry, sir. Pertuzumab, loading dose is 840 followed by 420 maintenance dose, sir. 840 milligram.
Okay, trastuzumab.
Trastuzumab loading dose is 8 milligram per kilogram followed by 6 milligram per kilogram maintenance dose, sir.
Okay.
After 6
So,
cycles. Yeah.
this is case. According to the PET scan, your stage is substaged with your
Yes, sir.
clinical examination.
Yes, sir.
If it is a stage 1 HER2 positive breast cancer,
Yes.
how will you approach?
Sir, even if it is stage 1, if it is more than stage 1C, more than 1 centimeter, I need to give chemo plus anti-HER2 agents, sir, as neoadjuvant.
So, in that scenario, also you would like to go with the dual blockade or single?
So in that case, also I will prefer dual HER2 blockades.
Small tumor,
Dual
T1 only.
So most of the trials, only trastuzumab was given, but giving pertuzumab also has. There are some trials which tried giving pertuzumab at that early stage also, sir. So I will prefer adding pertuzumab.
So what is the idea of giving single or dual HER2 blockade? What is the idea of giving this dual or hello?
So to improve the PCR rate, sir.
PCR rate, okay. So will the PCR rate improve by addition of pertuzumab in T1 tumor?
So PCR rate is around 45 to 50%, sir.
Sir is asking if adding pertuzumab, if the PCR rate is going to improve.
Yes, sir, it will improve, sir.
T1 tumor.
Around 5 to 10% it will improve, sir. extract 5 to 10%. So in the neoadjuvant trastuzumab alone trials, the PCR was around 45%. The dual HER2 trials, it has around, the PCR rate is up to 60%.
Okay.
Okay, if there's a patient is upfront underwent surgery, so some surgeon is operated and the patient come to you with this HER2 positive result. Then what is your choice of adjuvant treatment?
So adjuvant in this particular patient, I will avoid the anthracycline, sir. In that case, I will give it docetaxel and anti-HER2 adjuvant treatments, sir. Dual anti-HER2 adjuvant.
Dual.
Yes, sir.
Why you want to do a dual?
So you have to look at the pathological report.
Yes.
So pathology report is COIMBATORE T2N0.
Okay, sir. PT2.
Then what is your
N0.
Okay, N0, I will give single HER2, sir.
That's what you meant.
Yeah. So the same patients you can consider if a postmenopausal lady, elderly, 59-year-old female, so upfront underwent surgery and comes to you with a HER2 positivity.
Yes, sir.
You can look at the ER positive or negative. So the same patient, the ER positive, HER2 positive comes to you with the T2N0, which is your preferred regimen.
So ER positive.
ER positive, HER2 positive, pathological T2N0.
So then I'll go ahead with taxane and trastuzumab alone, sir.
Yeah, very good. So there is some difference with ERPR negative and HER2 positive, and ERPR positive and HER2 positive disease. Better go with the weekly regimen, isn't it? Weekly Paclitaxel and weekly trastuzumab, and followed by you can continue the trastuzumab for 1 year.
1 year, sir.
Yeah.
So this patient.
How will you?
Yeah.
Sir,
Proceed,
proceed, sir. So how will you monitor the cardiac function in every cycle?
So when giving trastuzumab, every 3 cycles we need to do a echo, sir.
Oh.
Look for the percentage reduction if there is any in the ejection fraction. If there is a 10% reduction,
Okay.
or if it goes below ejection fraction 50, then we need to withhold the drug, sir.
Okay. So how many cycle you withhold, or can you restart again?
So if the ejection fraction comes back to normal, we can restart, sir. I mean,
Yeah.
Okay. Yeah.
because the trastuzumab mediated cardiac damage is reversible, sir. So
Yes.
we
Can be rechallenged. Okay.
rechallenge.
Oh.
Yeah. Dr. Priyanka,
Yes, sir.
Arabam, can I just start?
Yes, sir. Yes, sir.
So you have very clear guidelines when to stop trastuzumab and when you can restart trastuzumab. So I think Dr. Aramam has asked a very specific question. So let us say your patient had a baseline echocardiogram with an ejection fraction of 55%.
Yes.
And now you are serially monitoring the echo. So when will you stop trastuzumab? What is the criteria? You say that your patient is going through the 6th or 7th trastuzumab. She is hypertensive for the past 15 years. You only said that. So when do you think you have to stop trastuzumab?
So the absolute reduction.
When will you stop trastuzumab in your
Absolute reduction of ejection
Correct.
fraction
Please proceed.
is more than 10%, or it goes either from the baseline, or if it goes below ejection fraction of 50, we need to stop, sir.
Very good. And when can you restart? When can you restart?
So if the injection.
At what will be the criteria you want? So now let us say many of the echocardiograms give about 66 or 65%, 70%. So from 70, there is a drop to say 59. That means it's crossed 10%. So when will you restart? When it becomes 63 or 65 or 70 or 72? Are there guidelines for
Yes,
stopping and starting
I
dressing?
can't.
Please go
So
back and
I'm not able
read
to
that.
recall. Okay, sir.
So if you want to protect the heart,
Yes.
once the patient has had shifts in the echocardiogram, what drugs you would like to employ in a patient to prevent further drop? What are the drugs that you can use? Are there trials for that?
Dextrosine can be given, sir. Dose.
So what is it? Dextrosuxin.
Yes, sir.
Or
Dextrosuxin for trastuzumab toxicity.
So for trastuzumab, it is reversible, sir. Dextrosine we use for anthracycline toxicity, sir.
what's the difference between anthracycline toxicity and trastuzumab-induced cardiotoxicity?
Anthracycline toxicity is an irreversible damage. The damage will be caused to the cardiac myocytes. There will be a reactive oxygen species mediated damage to the cardiac myocytes, which is irreversible, sir. Whereas in the case of trastuzumab, it is a reversible type of cardiac damage.
So that is type 1.
Ah.
This is type 1 and this is type 2. So it's about cardiac remodulation. So what are the drugs which are used that can prevent, that can aid cardiac remodulation that you use even in normal congestive cardiac?
So that is angiotensin AC inhibitor, sir.
AC inhibitor. So are you aware of any trials, positive or negative trials for trastuzumab cardio prevention of trastuzumab toxicity?
No, sir.
Sure. That's fine. No problem. Please proceed.
Okay.
Normal, many of the questions you can.
Yes. So how will you proceed after completion of this 6 cycles your planned regimen with TCH with P? Then what is your next line of management?
So we'll send the patient for surgery, and I'll look after surgery. I will see the histopathology report and decide on the further management.
What will you expect in the post-op pathology?
So I'll look for a pathological complete response. Sir.
So what is the definition of pathological complete response?
Pathological complete response is there is absence of any invasive component in the primary as well as in the axillary node symptoms. Invasive component. So there is
Okay. If the patient is not, if the patient is achieved, one set of patient is achieved PCR and one set of patient is not achieved PCR, then how to go about it?
Those who have achieved PCR, I will continue maintenance trastuzumab, pertuzumab up to 1 year. And those who have not achieved PCR, I have to switch to trastuzumab emtansine, sir.
Yeah. Okay. How many cycles you will plan?
So 14 cycles, sir.
For TDM1. So if the patient achieved PCR, you have used dual blockade upfront. So how many cycles you will give?
Sir, up to total 17 cycles, sir. Up to 1 year, I have to continue, sir.
Okay.
Trastuzumab and pertuzumab.
Yeah. Okay. Then what is the follow after that? So this patient is ER positive. And you are giving dual blockade as maintenance. And what is the follow-up after 1 year?
So she is postmenopausal, so I'll add aromatase inhibitors, sir, as adjuvant endocrine therapy. Letrozole I will add, sir.
Okay. So what is the follow-up schedule? How
Sir.
in your institute, how you are following the patient?
Sir, after treatment completion, for the first 2 years, we'll see the patient every 3 to 4 monthly, sir, and do the clinical breast examination. And then after 2 years, up to 5 years, every 6 monthly follow-up, sir. Then after that, a yearly follow-up. And mammogram will be done every annually, sir.
Hmm.
And
Okay, 2 years down the line, the patient has developed some symptoms and presented to you, and you have did some investigations like PET or CT, whatever. So you have find out some lesion in the liver.
okay, sir.
How will you approach?
So single liver lesions.
You can take it as a multiple liver lesion, and the largest is around 4 to 5 centimeters.
Sir, I will proceed with the histopathological confirmation from the suspected metastatic lesions.
So you want to do rebiopsy?
Yes, sir, rebiopsy and IHC
well.
score, sir.
Why you want?
Okay.
Why you want to do? Because already established case and PET says increased uptake, classically liver mets. Why you want to do biopsy?
There is chance of discordance with the IHC report, sir. There is chance, so accordingly my treatment will change. So there is more chance of an ER positive becoming ER negative in the metastatic settings. So I would like to know that. So I proceed with the repeat biopsy.
Based on the duration of endocrine treatment, is it what type of relapse is it?
So,
Like sensitive or resistant relapse?
so for this patient,
Yeah, he said 2 years. No, the patient is developing liver lesions after 2 years.
yes, sir.
Okay.
Sorry, it's an
Sort
endocrine.
of the what sort of preference?
Resistant.
Hormone sensitive or hormone resistant?
Resistant because she developed meds while on endocrine therapy, sir.
Is there any duration?
So I think,
When will you say sensitive relapse?
sorry. After after completing the endocrine adjuvant endocrine treatment, I think 2 years.
2 years. You completed 2 years of endocrine therapy, but reckons still endocrine sensitive. This patient is says 2 years. No. So,
Yes, sir.
okay. So if it's 3 years, last 3 years,
So then it is sensitive, sir.
then what will you do? So what will you do? If it's sensitive, if it is what will you do? Yeah.
Next level of endocrine therapy with
What are
selective
the things you will see? What are the things you will see before going ahead with the endocrine or?
Sir, I will see first I will confirm the sites of meds and whether the patient is in visceral crisis. The patient is not in visceral crisis, I can give endocrine therapy alone for the patients.
If this patient 2 years means, what will you do?
So I will give a selective estrogen receptor downregulated fulvestrant, sir.
For 2 years means maybe less than 2 years, maybe one
And a CDK4 inhibitor, sir.
20 months. 20 months, what will you do? Relapse within 20 months. In 20 months. Liver mets in 20 months of endocrine therapy.
Sir, fulvestrant plus CDK4 inhibitors.
So you said endocrine resistant, no? Within 2 years. Still you want to continue with the endocrine management.
That means I have to look for other mutations, sir. ESR1 mutation.
Hmm.
Those mutations I had to see and
Okay.
give the therapy accordingly, sir.
Do you offer for this patient radiotherapy?
Yes, sir. Because it was a prayer T2N1 disease, sir.
So by clinically you told it is
Clinically, it was
T2N1 and
T2N1. So if the patient is and like patient is planned for a BCS, I'll definitely patient definitely needs RT, and patient is planned for MRM. I would like to see the HPR report and decides.
The PET says
So-
memory notes is the 2B, no?
Yes, sir.
Yeah.
So memory notes are positive, so definitely I will give RT, sir.
Okay, what is your treatment plan? Your treatment plan is for upfront clinical examination or post-op pathology report.
Sir, upfront.
Yeah, your plan of treatment is for upfront diagnosis, not for the after neoadjuvant chemotherapy. If the patient is achieved PCR, you should not omit RT. Even in T2N1,
Yes, sir. We need.
what is your plan of treatment? So initial plan, you have to write everything. So neoadjuvant chemotherapy followed by surgery, then you have not tell about radiation in this patient.
Yes.
Mm.
So it is a neoadjuvant chemo followed by surgery followed by adjuvant targeted agent and adjuvant RT and adjuvant endocrine therapy, sir.
Okay. So this patient is our plan of treatment is a TCH with the P, isn't it?
Yes, sir.
So TCH with the P, and what are all the complications you can expect with this TCHP other than the cardiac?
So carboplatin, the bone marrow suppression due to the chemotherapies, neutropenia,
Okay.
thrombocytopenia.
What is the chance of chemotherapy-induced nausea and vomiting in this regimen? Is it a high risk or moderate risk or low risk?
So carboplatin AUC more than 4 is high risk.
Okay, so it's a high risk category. What is your preferred pre-medication?
So for highly metogenic, I will need a 4-drug regimen, sir. So I will include an NK1 receptor antagonist, 5-HT3 receptor antagonist, steroid, and olanzapine, sir. So
Okay. Can you offer for prophylactic GCSF in this patient, in this regimen?
yes, sir. So need prophylactic GCSF, sir.
Yeah, you have to tell. So you have to give prophylactic GCSF for this patient. Okay. Okay, sir. Any more other questions, or can go for the next case?
It's 8:45. Okay, we will go ahead with the short case. Okay.
Okay.
Okay, Brekka. Proceed with the next case.
proceeding with the short case. It's a 42-year-old male, tea estate worker from Valaya. He presented with the complaints of swelling right side of neck for past 8 months. Patient was apparently normal until 8 months back when he noticed a small swelling upper aspect of right side of neck, which gradually increased in size.
Short case, I think you just have to summarize in
Yes.
2 lines and go to findings, Dr. P.
So it's a 42-year-old male with no comorbidities, non-smoker, non-alcoholic, presented with a swelling right side of neck for the last 8 months duration. So general examination was normal. Vitals were normal. Local examination, inspection, there was a swelling on the right side of neck in the submandibular region. On palpation, there are multiple swellings palpable. Swelling of size 2 cross 1.5 centimeter at the right level 1B region. Another swelling of which was firm in consistency and mobile. Another swelling of size 2 cross 2 centimeter at the right level 2 region, which was firm in consistency and mobile. And there was another swelling of size 2 cross 2 centimeter at right level 3 region, which was firm in consistency and mobile. And
what do you think these swellings are?
these are lymph nodes, sir. Lymph node enlargement, sir.
What are the other swellings that can come in this region?
So there can be any salivary gland swelling or thyroid swelling can come, sir.
Okay. After clinical examination, do you feel it is any of the other differential diagnoses like thyroglossal cyst, or you feel it's a pharyngocele or laryngocele or anything?
No, sir. No other features suggestive of that. It is a
So
superficial
when
swelling.
you're presenting,
Ah,
see, since now this is a super specialty examination,
okay.
when you're very sure that it is a contiguous group of lymph nodes that is quite firm and large, you can confidently say that this patient on examination is having level 1 to level 3 involved nodes. Are they firm, tender, non-tender, bulky, non-bulky, matted, not matted, with or without fistula? So, and you directly go, to the next. That don't give too much of description.
Okay, sir.
Because then, it tempts us to ask, now how do you differentiate a pharyngoscele and a node? And then, it goes into tangential discussion. So when this is a very clear case, you have a lymph nodal mass on the right side of the neck. Any other nodes are there in the neck?
No, sir. Not
Only
very
unilateral. No,
unilateral.
it's a unilateral neck.
Cervical
So, and thyroid is normal.
thyroid is normal.
Any other, what else did you examine in this patient?
Sir, I will examine the oral cavity and the oropharynx also, sir.
Anything else?
Look for other lymph node regions.
Anything is there?
So no other positive findings, sir, in the systemic examination or examination of other lymph node regions.
Okay, so this is a short case.
Yes.
45-year-old, 8 months duration, right? Level 1 to level 3.
Yes.
Lymphadenopathy. Matted,
Yes.
not matted.
Non-matted, sir.
So multiple nodes.
Multiple nodes. Non-matted.
Take that. So this presentation should be over in 5 minutes.
Okay.
So that the remaining 15 minutes, your examiners will ask you questions.
Okay.
Prabhakar sir, please go ahead, sir.
What do you think of this swellings, the lymph node swelling?
So it's a right-sided cervical lymphadenopathy without any symptoms of any the symptoms suggestive of any primary anywhere in the oral cavity or pharynx. So I'll give it's a secondary deposits from unknown primary. That will be my first PD, sir. Or it can be a lymphoproliferative disorder considering the short onset of history.
You said there's no symptoms or clinical examination suggestive of any head and neck or thyroid primary, then we want to tell secondaries first. Your DD.
So that those are my malignant DDs, sir. I'll keep also non-malignant DDs like infective causes like tuberculosis.
In malignancy also, why you want to say secondaries when there is no symptoms or a clinical examination suggestive of any primary in them? Why you want to keep the secondaries?
Sir, there is the head and neck.
There could be a primary of the lymph node instead of a secondary in the lymph node.
Sir, many of the head and neck malignancies like nasopharynx can present without any symptoms, like lymphadenopathy alone as the symptoms.
Okay, Dr. Priyanka, 1 minute. So here the take home point is your examiner is trying to give you a lead. So take that lead. You have examined the oral cavity, the cheek is normal, gingiva is normal, tongue is normal. Hopefully you have examined everything right, correct?
Yes.
Okay, so you have examined everything right. Ideally, when you are going to the exam, in your examination center, you are supposed to know how to do ideal also. So let us assume that you have done an ideal also for this patient and everything is normal. Okay, so he is, Professor Prabhakar is giving you a lead that there is nothing else clinically in the oral cavity. So why do you want to consider it as a secondaries in the neck as your first DD? When you have isolated discrete lymph nodes in the neck. Now, second point, clinically, how do you differentiate between secondaries in the neck and lymphoma in the neck?
So from the
Let us assume that it really became a COP. But how do you differentiate between the two by looking at the node?
So from the consistency of the node, we can differentiate, sir.
So what is the consistency of your node?
Like it is firm in consistency, sir.
Firm,
So
but how is it in squamous cell carcinoma?
that
Firm
will be
too?
hard, sir.
Okay, your patient is having?
Firm in lymph node is firm in consistency, sir. But
Okay.
incidence wise, the lymphoproliferative disorders are down the line, sir.
Correct. So that is how you defend your answer. But when you don't find an obvious primary in the oral cavity or nasopharynx, which we assume you have examined by an ideal, it's better that you'll be appreciated well if you bring the CUP in the second AD. We can say that there is multiple node. Now I'm coming to the question. Now you said it could be NPC. What will be the presentation of a? See, there are multiple nodes. It has come all the way up to level 3, correct?
Yes, sir.
So if you have a nasopharynx with up to level 3 or even level 4 involvement, when do you suspect a nasopharyngeal malignancy by examining the neck nodes?
So nasopharynx, it will be a bilateral lymph node presentation, sir. Most common will be.
Correct.
bilateral.
Because it's a midline. Most of the time, by the time the tumor reaches to level 2, level 3, you will have the opposite side also involved. That is why the nasopharynx staging is very different.
Yes.
Right? And then when you have a bilateral supraclavicular nodal involvement, once again, that goes more in favor of nasopharynx. So these are very strong clinical pointers towards nasopharyngeal primary with the neck nodal.
Okay.
So once again, you have to go back to Dr. Prabhakar's point. When you don't have something very obvious in the oral cavity or cheek or tongue, then when you have a soft to firm node involving 1 to 3 level nodes, not matted, not hard, still you can keep back with a lymphoproliferative disorder as your first defense. Okay.
Okay, sir.
Can this be leukemia? Can this be a leukemia of the nodal presentation?
So without any constitutional symptoms, this
Need not be there.
No,
Need not be there. Constitution need not be always there. Can this be a leukemia with a nodal presentation coming to you with this kind of a presentation?
It can, but there are no other features like any splenomegaly or any other features, sir. But there is
Other than splenomegaly, what else is not there?
So,
what's the difference between the clinical findings of a Hodgkin versus a non-Hodgkin lymphoma? What if you find when you're doing a nodal examination,
yes.
What tells you that one could be Hodgkin? What tells you one could be non-Hodgkin lymphoma?
So the pattern of spread we can differentiate, sir. In Hodgkin,
just go ahead. Just tell the points.
Contagious spread in Hodgkins, non-contagious in non-Hodgkins.
Good, proceed. Next. What else?
Then
contiguous versus non-contiguous. Next.
Sir, in Hodgkins, it will be non-Hodgkins. There will be more extranodal presentations.
Hodgkin will have extranodal.
No, non-Hodgkins.
NHL will have extranodal presentation, whereas extranodal is rare. Next.
Then more chance of T symptoms will be with Hodgkins, sir.
Tonsil involvement.
Tonsil involvement is more with NHL, sir.
Okay. Age of presentation.
The age of presentation is bimodal for Hodgkins, sir. NHL
That is non-Hodgkin.
any age, sir.
Can come in any age, but incidence wise, it keeps increasing with age.
Yes.
What node, if present, tells you that this is unlikely to be Hodgkin? Let us say you have a stage 3 disease in either of the case. Okay, but you say this node is present, so likely to be non-Hodgkin. What are those peculiar group of nodes which, if present, is non-Hodgkin?
So the epitrochlear, preauricular, and popliteal nodes.
Very good. So in this case, when you say when there is a leukemic involvement of the lymph nodes, let us say ALL with lymph node involvement, is it a more like an NHL presentation or a HL presentation?
That is NFL presentation, sir.
So patient will have multiple generalized lymphadenopathy, right? The patient will be more sick.
Yes.
Patient will have a generalized lymphadenopathy. Here you are having only a just a single group of nodes involved in the right side of the neck,
Okay.
right? So when you say a lymphoproliferative disorder, you should be able to quickly branch off into Hodgkin.
Okay.
Okay, so your professor has given you a very classic presentation. So when you have to be more careful in your presentation when you have a very clear classic case, so that it is staring at your face. Don't pull in differential diagnosis just for the sake of discussion. If
Okay.
it looks like Hodgkin, say it looks like Hodgkin.
Okay.
Okay. Sorry, Vibhakar sir, I came in. You can continue.
No, sir. No, sir. You can continue, sir. No issues. So what will you do now, Priyanka?
Sir, I will go ahead with basic blood investigation, complete hemogram, ESR, the peripheral smear, LDH, LFT, RFT. So after that, I will look for any clue for my diagnosis of lymphoproliferative disorder in the blood investigations, and also I'll do a serology, including EBV and HPV, sir.
Then
And I will.
Whoa. I request everybody to mute their mics except the presenter, please. Please consciously mute your mics. Yeah, Dr. Priyanka, see, once again, we tell repeatedly to all the candidates, how do you want to proceed further? Do it in the flow. Imagine you're sitting in the outpatient department. This patient is sitting on a stool next to you. You have done the clinical examination. There is a single group of lymph nodes on the right side of the neck that is involving level 1 to level 3. And Prabhakar has asked you what you want to do next. So when you are going to that, you just say, I would like to get the routine investigations, including CBC, routine biochemistry investigation, viral markers. I would like to look at a coagulation profile. No, that has to go in one line, in a flow. Okay. So you don't go one by one. So now you came with EBV and so many things. Do you do EBV routinely in your hospital in the outpatient before sending this patient for a tissue diagnosis?
No, sir, we won't sense.
Then why did you commit about EBV? So you are working backwards from Hodgkin and going back and telling about EBV. That's number one. And number two, by finding an EBV serology, is your management going to change?
No, sir.
Okay. In which malignancy, finding an EBV, your management will change?
So if it is nasopharynx.
Correct. So you can add these points later, right?
Okay.
Just say, I would like to look at a CBC. Now, why CBC? If I say why CBC, what are you going to specifically look for in CBC? One point you look for in CBC.
I'll see the total counts, sir. Because I
want to rule out leukemia. One word. So you have to talk like a consultant.
Okay.
I want to rule out leukemia. That's it. So patient with a 20,000 platelet, if you send for a biopsy and then the patient comes back bleeding with a hematoma or dies in the theater, you will be pulled to court. Only yesterday we had the TAMPOS medico-legal session. So I hope you people listen to it. So these kind of errors can occur. So I would like to do a CBC to rule out leukemia. So now I'm coming back to your case. If you already came to know that this was a Hodgkin and then still I insist, Dr. Priyanka, tell me what would you like to specifically look for in the CBC? Are there any specific CBC patterns that are related to Hodgkin lymphoma?
CBC.
any particular differential count which could be reached in Hodgkin, peculiar to Hodgkin?
Not sure, sir.
Okay, you can just go back. Usually you can have blood or tissue eosinophilia that is associated with Hodgkin. Okay, fine. So next you go for the basic blood investigations and you finish everything and then you do a biopsy. The biopsy has come as lymphoproliferative disorder, query Hodgkin. So can you describe what is seen in a Hodgkin lymph node?
So Hodgkins. So in Hodgkins, the malignant cells are the Reed-Sternberg cells, sir.
Yeah,
So-
what percentage of the cells are the malignant
So
cells?
that will be the minority. It's like minimal number of
Yeah.
malignant cells surrounded by
Roughly,
majority.
can you give a ballpark figure? Let us say you have 1,000 cells with the pathologist counts in one section. What would be the percentage of your malignant cells?
Maybe sir 5 to 10%, sir.
That's a very high percentage. So it's going to be 0.1 to less than 1%. Okay. So what are these Hodgkin cells?
Sir,
What is this Hodgkin cell that you're seeing?
sorry, sir.
No, what is Hodgkin cell? You said you are going to look for Hodgkin cell. So what is
Yes,
this
sir.
Hodgkin cell?
So they are
Is it a myelocyte or a lymphocyte or is it a
post-germinal center B cells, sir. So
okay?
they are
Is it a B cell
it's a
accepted?
post-germinal center B cells, sir.
So what is it? What is it? How does it look?
So it appear multinucleated, bilobulated,
Bilobulated,
binucleated,
binucleated.
and multinucleated, sir.
Can be bi or multinucleated. So they are basically giant cells, right? So
They are giant cells which
what are the correct? So they are binucleated mostly, or they could be even multinucleated giant cells.
and
So
prominent.
can you tell me
prominent is
correct? Correct. So in Hodgkin, apart from finding the Hodgkin cells, what are the other important findings that are there in the node which tell you that this is leading to a Hodgkin lymphoma?
That is the surrounding inflammatory infiltrate will be contain small lymphocytes. Then plasma
Which
cells.
Hodgkin lymphoma? In which Hodgkin lymphoma you may not be able to get this typical inflammatory reaction, and you'll have more of florid macrophages, tumor macrophages. Hodgkin cells are seen all over the place, even sometimes in sheets, but there is no inflammatory reaction.
It's in lymphocyte depleted, sir.
So in which population do you get lymphocyte depleted Hodgkin?
So in lymphocyte depleted,
who cannot elicit a immune reaction?
sir, usually seen HIV positive cases associated with immunosuppression.
Patients Hodgkin with immunosuppression, you may not be able to get that typical inflammatory reaction, right? So
Yes.
can you tell me a typical immunomorphology of a Hodgkin lymphoma? What will you ask your pathologist? The markers you want on your
Sir, markers.
I get seen this.
Sir. Basically CD15, CD30, and PAX5, and that is for classical Hodgkin lymphoma, sir. That will be positive.
Okay.
And the surrounding inflammatory infiltrate can have CD20 positivity, sir.
Okay.
And if it is nodular lymphocyte predominant, it is typically CD15, CD30 negative, and it will be CD19, CD20 positive, sir.
Very good. What are the morphological mimickers of Hodgkin?
Sir?
What are the morphological mimickers of Hodgkin lymphoma? Where IHC only finally helps you. You have a lot of inflammatory reaction all over. You have background T cells. You have some multinucleate giant cells. You have some B cells.
Viral.
Morphological mimickers, which are also lymphomas.
Sir, there is a certain NH like T cell rich
Very good. T cell rich.
NSL, sir.
TCR, BCL. Okay. What else? What else? If there is a CD30 positivity and you have atypical large cells, what are the other lymphomas you would like to know? Which are the lymphomas are CD30 positive?
That's given a clue. Size of the two cell he has told me.
You have to look at ALCL also.
Yes.
Right?
So I said, no,
So
large
if
cell, no, some large cell.
CD30 is positive, but CD15 is negative, CD35 are positive, it goes into the T cell lineage. Okay. So see, when you are getting a case of lymphoma and it's a Hodgkin, all of us know that the treatment is ABVD, and most of you people will know what it is going to be. So when you have a very simple short case, you're ready for more tangential discussion rather than a straightforward. Nobody's going to ask you what is ABVD and what is bleomycin toxicity and all those things. Right?
Okay.
So you should know what are the mimickers of Hodgkin lymphoma, what are the types of Hodgkin lymphoma, where do you get lymphocyte depleted variety. So HIV and Hodgkin, what are your thought process? Does it come in which phase of the HIV infection do you get DLBCL, and which phase of the HIV infection do you get Hodgkin? When you find DLBCL in a patient, when you have DLBCL in a patient which is a known patient with HIV infection, what do you call it?
So that is an HIV defining.
HIV defining.
No, sir.
What's the end of the spectrum called?
Mm.
It's an ADC, AIDS defining criteria, right?
Yes.
Finding squamous cell carcinoma of cervix or finding, DLBCL or a primary CNS lymphoma is an AIDS defining criteria. So when the patient goes through the entire HIV, so what's your guess on the CD4 count when a patient develops DLBCL and HIV? Will it be high or low?
Low, sir.
It will be very low. So when uncontrolled HIV progresses and the CD4 drops, the patient tends to get DLBCL. In which phase of, where do you get classic Hodgkin lymphoma in HIV patients? It is usually EBV associated. It comes during the phase where the CD4 count is good, because for Hodgkin, the inflammatory reaction to the Hodgkin cell is more important for development of lymphomatous signs, right?
Okay.
So in Hodgkin, just like bimodal presentation in age, you also have a bimodal with the CD4. So majority of the Hodgkin come when the CD4 counts are normal. And then Hodgkin can also come during low CD4, where you have the lymphocyte depleted variety, where there is no lymphocyte immune reactions. So you can have both ends of the spectrum. So when they come with a normal CD4 count, it presents like any other Hodgkin lymphoma. Your treatment is also like any other Hodgkin lymphoma. But when they come in low CD4 count, they are the usual lymphocyte depleted variety. They are usually present as intra-abdominal disease, extensive disease, extranodal involvement. Whatever you said is typical for non-Hodgkin lymphoma. Those kind of findings you will find in Hodgkin lymphoma when the CD4 is well. Otherwise, it presents as a classical Hodgkin. Okay. So this is sometimes a very favorite question which is brought up by the examiner. So you have to know about HIV associated. Okay. So for this patient, what is the stage, Dr. Priyanka? Clinical stage.
It's a stage 1 disease, sir. Stage 1A.
Okay. So early Hodgkin.
Early favorable disease, sir.
What staging investigation do you want?
So staging investigation.
Correct.
I need a PET CT scan for staging, sir.
Okay, good. You can ask for PET-CT. See, whatever you do in your institute, once again to all the postgraduates sitting here in the presentation, whatever you do in your institute, you please tell in the exam. You're not wrong. Okay. You can say, as per our institution protocol, we do a PET-CT, because there can be some examiners who may jump at you and ask you why PET-CT. Okay, so you did a PET-CT, and the PET-CT shows a localized nodal conglomerate nodal mass involving the right level 1 to level 3. Accepted. So now 1A Hodgkin. So how do you restratify? How do you restratify early Hodgkin?
Sir,
How do you stratify advanced Hodgkin? How do you stratify early Hodgkin?
early Hodgkins I will stratify based on the GHST criteria, sir, into favorable and unfavorable.
Yeah. So what are the 3 criteria in GHSG or the
Sir, is
WHO or the
ES
NCA? You can use anything. Yeah.
ESR more than 50 or ESR more than 30 with these symptoms. Any extranodal involvement, more than 2 nodal sites, and MMR ratio more than 0.33, sir. These are the
Okay.
fair.
But in your, when Prabhakar asked you about the what you want, you said CBC, you didn't ask for ESR.
Yes, sir, I said ESR, sir.
You said ESR, I'm
ESR
sorry.
and LDH.
So what is the ESR for this patient?
Sir, it was 12 only, sir.
12. Okay. So does this patient have any of the high-risk features?
No, sir.
So what
It's
is your
not
final
very-
diagnosis?
No.
What is your final diagnosis?
So it is stage 1A favorable Hodgkin's disease.
Very good. So
So
what is
can
the
I
treatment
ask
plan?
one?
Yes, sir. Yes, sir.
Hello.
Yes.
So, doctor, can you do bone marrow biopsy for Hodgkin's disease as a staging workup?
So if you are doing a PET CT, then there is no need of doing a bone marrow for Hodgkin's. Unless there is some unexplained cytopenia without any PET positivity, we can then plan for bone marrow. Otherwise, if you are going ahead with a PET, there is no need of bone marrows.
So,
No.
is there any
Which Hodgkin do you do bone marrow? Dr. Armugam is very clear.
Yes.
Which Hodgkin lymphoma stages you have to do bone marrow?
So
Does not depend on whether PET or non-PET. Okay, tell me what is the bone marrow finding? What is the PET finding if there is bone marrow involvement in Hodgkin? What is the PET
Hodgkin's.
finding if there is a bone marrow involvement in non-Hodgkin? Because you are going to go only by the bone marrow findings, and you say you can avoid doing a bone marrow biopsy, then we should know the typical findings on PET, which will say its involvement. Is there any difference between HL and NHL in PET when bone marrow is involved?
Sir, in Hodgkin's, homogeneous enhancement, sir, and more than 3 focal areas of involvement, sir. That is,
That's on MRI or that's on PET scan?
that's
Yeah, is there a multifocal involvement?
Yes.
Multifocal.
Yes. Multifocal involvements.
Yeah, okay. So, but any advanced stage, is there any need, or in the early stage can we avoid, or in advanced stage you have to do bone marrow biopsy in spite of PET scan negative?
Sir, if there is any cytopenia present, which is unexplained cytopenia, we need to do a bone marrow biopsy then. Sir, even if the PET is negative.
So he's clearly asking, is there any stage, any particular stage you want to do, liver on the cytopenia?
No, see, you have told all the answers, but you have told it in bits and pieces like puzzle, Dr. Priyanka.
Okay.
So Dr. Armugam has asked a question and you have given the answer. So patients with presence of B symptoms, basically 2B onwards, stage 1 to 2A, technically you don't need a bone marrow biopsy. And all these questions were answered in the pre-PET era, but still holds good.
Okay.
Any patient with B symptoms, any patient with stage 3, or especially patients with stage 4, you have to go ahead and do a bone marrow biopsy.
Okay, sir.
But if you do a PET scan and PET scan unequivocally finds bone marrow involvement, then you can avoid. So what Dr. Armam asked you is where you have to do,
Okay, sir.
and you are trying to tell where you can avoid. So be very clear with that. So where you have to do 2B, 3, 4.
Okay, sir.
Where you can avoid unequally finding involvement on PET scan, you may avoid, and that too in Hodgkin. But in non-Hodgkin or DLBCL, still it is a
We need to do so.
debatable area. So you have to see the pulse of the examiner and give the answer
Okay.
instead of trying to argue with them. Okay, please go ahead.
So stage
So
one.
how do you want to treat this patient?
Sir,
What's your institute protocol for treating this patient?
stage 1 favorable, we'll go ahead with chemotherapy, sir. Combination chemotherapy with ABVD.
Doses?
We'll do a peptidopter treatment, sir.
Doses?
ABVD 2 cycles, and then we'll do an
Dose of ABVD?
adriamycin 25 milligram per meter squared, bleomycin 10 units per meter squared, and vinblastine 6 milligram per meter squared, and dacarbazine 375 milligram per meter squared. And day 1, day 15, ends in 28 days for 2 cycles, followed by interim PET assessments.
First cycle ABVD, what precautions do you take? Your junior is on call. This patient has got admitted at 7 p.m. So you have to give ABVD and discharge the patient. So let us say the patient's in daycare. So what are the precautions that you will take while giving ABVD? What among the 4 drugs can cause reactions, anaphylactic reaction? Have you given ABVD bedside or have you
Yes, sir.
personally given? So in the 4 drugs, which one would you be very careful with?
Usually
Common side effect? Infusion reactions.
infusion reaction, it's rare, sir, but
Which drug amongst the 4 will cause infusion reaction? Okay, we'll go one by one. Adriamycin, what are the precautions you have to take, Dr. Priyanka?
sir, before chemo, we will get a cardiac evaluation with echo, sir.
That is normal. Next. No,
Bleomycin.
patient is already pushed for the daycare. So we assume everything is fine. Obviously, you're going to ask for a DLCO, and these are all the exam
Bleomycin.
questions. So that's all you would have done. So you're pushed now. Now tell me, what are the precautions for doxorubicin?
So it could be, we should be like, any risk of extravasation should be avoided, sir. Then
Color of doxorubicin?
red, sir.
Okay. So do you give it as an infusion or do you give it as
Sir, it's given as a bolus side push, sir.
given as a side push? Very
Yes,
good.
On an,
With an IV fluid which is running.
yes,
right?
sir. On an ongoing
Okay.
saline plus side IV push.
So when do you suspect extravasation? Have you given or your chemo
Sir,
nurse gives?
no, sir. We have seen cases of extravasation, sir. When the patient has
Yeah, no, I'm asking you, do you push or your chemo nurse pushes?
sir, staff nurse will push, sir.
Very good. So what instruction will you tell the staff nurse? When do you have to stop the infusion?
So I'll ask them to avoid any pinching of the line or anything, sir. And if the patient complains of any irritation or any redness around the region, we have to immediately stop the drug.
Okay. So your patient says that she starts complaining of pain and there is a small bulge proximal to the cannula. What are the immediate steps that you will take?
So I have to immediately stop the infusion, sir.
Stop. Next.
Stop, and if possible, I can aspirate out.
Very good.
Possible.
So I have taken back to 2 cc, up to 2 cc. I was able to aspirate.
Aspirate.
The next.
So then we'll keep cannula in place only, sir. Then for anthracycline, I have to give a cold compressor.
Very good. Where do you give warm compress?
Vesican. So for extravasation, cold compression is needed, sir.
Okay. Where do you give warm compress?
That is for a irritant or a
drug name.
Which drug?
tax Vinca tax.
Very good. So you have, okay. Anything else you can do?
So for anthracycline.
Extravasation. Yes.
Topical DMSO applications, sir.
Very good. What can you expand DMSO?
Dimethyl sulfate.
What? Excellent. What is the percentage of DMSO used in the?
The 10% DMS.
Sure. 10.
10.
Where,
One
from
person.
where do you get EMSO?
Mm. Sure.
Just go and check. You normally get it from the blood bank where stem cell preservation is done, right?
Oh,
It's very expensive. You get a small. So usually 100% is available everywhere. Some places you get 50% also. Okay, so you take the DMSO and any other drug that can be used that can prevent extensive fibrosis around the site of extravasation that can be given as an injection.
Sir, if it is a irritant, then hyaluronidase injection can be given, sir.
So it is more in the irritant group of drugs you can enter. Fine. So this is with doxorubicin. Now, how do you give bleomycin? Infusion or push?
Suppose,
Yeah, bleomycin technically can be given as a push, but infusion, there are data to say that bleomycin injury may be little lesser. Fine. How do you give vinblastine?
so that's also a push release.
IV push through the rubber tube in a running cannula. Okay. How do you give dacarbazine?
Dacarbazine over infusion over 2 hours, sir.
Okay.
100 ml.
What is the commonest side effect patient tells as soon as the dacarbazine is started?
Dacarbazine.
Patient has intense itching and irritation along the line of infusion. Okay.
Okay, sir.
And after few ml of dacarbazine, patient can have technically allergic reaction and anaphylaxis. So in the 4 drugs, it is always the dacarbazine which is the problematic drug where you can get reaction. So you should watch for it. And sometimes you may have to double dilute and then initially start with a lower concentration of dacarbazine in some of the sensitive patients. So that was I was trying to ask him. So 4 cycles of ABVD and you wanted a PET scan. PET scan is dual 3. What do you want to do?
Dual is for 3.
Is this interim PET or end of treatment PET after
Sir,
4 doses?
2 cycles, sir. After 2 cycles, sir.
Yeah, two cycles. You said I will like to give 2 cycles.
Yes, sir.
2 meaning I mean 2 into 2, 4 doses, right?
Okay, sir.
So you have done a PET CT. PET CT is dual 3. What is IPET? What is IPET CR definition? What is end of treatment PET CR definition?
Sir,
Is there any difference?
interim PET CR is PS develop score 1 and 2, sir.
Okay, very good. So here patient is having 3
Yes, sir.
IPET. Will you take it as an ongoing response or do you want to take it as a want to go back and evaluate the patient?
We'll take it as an ongoing response and we'll continue with chemotherapy.
So how many more cycles do you want to give?
Sir, I'll give ABVD into 2 more cycles.
Okay, then what do you want to do?
Then I'll give Involsate 30 grade.
So you want to give a short course of ABVD, 2 to 4 cycle with ISRT, right?
Yes, sir.
Alternatively, you can also give 2 ABVD directly and IFRT. There are a lot of options in early stage. So you make up your mind what you do in your institute and your unit protocol and tell that in the exam.
Okay.
You have a 2 ABVD followed by 2 ABVD. You have a 2 ABVD followed by IFRT. You have a 2 ABVD, 2 ABVD followed by ISRT.
Then
You have some protocols of a 3 ABVD and IFRT. So, so many are there. So you don't give all options. You tell whatever is followed in your unit, you can tell the examiner. So I tell you have finished 4 cycles and still your junior resident asked for a PET CT and again it is coming dual 3.
If it is dual 3, we can wait for another 12 weeks, sir.
Dual 4.
Dual 4, I will need to do a biopsy, sir.
No, after 12 weeks, it has become dual 4.
Then we have to do a repeat biopsy, sir.
Why did you wait for 12 weeks after 4 cycles of ABVD and dual 3? If you have a dual 3 at the end of 4 cycle of ABVD, what is your inference for that?
At the end of treatment, dual 3 is like we have to suspect refractory disease and do biopsies.
Okay. Why do you want to do a biopsy?
So I need to confirm confirm the histology or any transformation has happened, sir.
Transformation. What transformation do you expect in Hodgkin lymphoma?
So if it is NLPHL, I will expect a natural transformation is possible, sir.
This is a classic Hodgkin.
Classical it
What-
is
What are you looking for inside?
refractory disease.
Okay. Or what else can be there?
Or it can be false PET positive, sir.
No.
It can
What
be
else can be there?
necrosis.
Let us say it's a disease. What is composite lymphoma?
Okay. There will be two histologies, sir.
There could be a composite lymphoma for NHL with Hodgkin. The Hodgkin component could have gone and the NHL will be continuing to grow because you have given ABVD kind of presence. These are all rare possibilities. In India, what else should you rule out in a Hodgkin patient?
Tuberculosis.
Very good. So there are enough papers to say there is association of tuberculosis with Hodgkin. Because of the immunological milieu, tuberculosis reactivation can occur due to intense inflammatory reaction within the Hodgkin node. So the tuberculosis also comes out. So sometimes we have had patients where we give ATT and ABVD together. Okay. So if there is persistent positivity, you expect what is the cure rate of early stage Hodgkin?
Was more than 95%.
Yeah. So when you expect a 90 to 95% event-free survival, and you're getting a 4 ABVD and a dual 3, either your diagnosis is wrong or you have a concomitant tuberculosis or you have a composite lymphoma. Okay. So that's how you have to take it. Otherwise, it's very rare that you will fail in a stage 1 Hodgkin. And in the rare event of failing, let us say the Hodgkin is still sitting there.
Yes.
By the time you end the treatment, the patient is now having a mediastinal node also. Biopsy is Hodgkin. So what is your diagnosis? No, you've treated ABVD into 4 and still, yeah, so can you define what is refractory Hodgkin lymphoma? What is early relapse? What is late relapse? Definition.
Early relapse is occurring within 1 year, sir. 1 year of completion of treatment.
What is refractory? Primary refractory Hodgkin.
So primary refractory is at the end of treatment, but if it is positive, that is refractory disease, sir.
No. There is a time frame, no? Up to how many months do you call it primary progressive? When do you call it early relapse? When do you call it late relapse? Go back and read.
It's occurring before 1 year and after that is late. Okay, sir, I'll read.
Just go back. Go back and read that. Okay. So if it is early relapse, last few questions. What do you want to do for this patient? Still curable or not curable?
Yes, sir. I'll stage and it's still curable with salvage chemo, sir.
What salvage chemo?
Salvage chemo, various options are there. We usually follow give ice chemo, sir.
You give ice.
And that will be followed by
how many cycles?
3 cycles and reassess, sir.
Let us CR after 3 cycles of ice. What do you want to do?
Let's CR, sir.
Yes.
I'll refer the patient for like to do a autologous stem cell transplant, sir. Hydrous chemo and autologous stem cell transplant.
What hydrous chemo do you want to give?
Sir, beam regimen, sir.
Can you expand beam?
BCNU, etoposide, cytarabine, and melphalan, sir.
Very good. What is the most common toxicity of beam? Okay, no problem. So you would like to do a transplant. So what is is there cure for this patient?
Yes, sir.
Primary progressive Hodgkin.
So it's cure rate is 50 to 60%, sir.
In primary progressive Hodgkin?
Primary progressive.
That is why I asked you the definition of primary progressive versus early versus late. Okay.
Okay.
Go back. All the three have different survival rates.
Okay.
It is still curable, but the percentage is very low in primary progressive, whereas it is very good in late relapse. Just go back and read that. My last question will be, if this was a DLBCL and end of treatment of R-CHOP, this patient came positive, what will be the approach that you will adopt?
End of 3 cycles, sir.
End of treatment. R-CHOP into 6. R-CHOP into 6.
Okay, sir.
Node is persistent. Node biopsy done. Positive for CD20 positive. Probable DLBCL. The same thing was DLBCL. Same case. Exactly ditto. You are very confident. Let us say it was stage 2 DLBCL. You treated with R-CHOP into 6 cycles. And you found most of it went and one node was persistent. You thought it's inflammatory. Repeated a PET after 8 weeks. Again, it is there. You go biopsy, it is DLBCL. Refractory DLBCL. What's your approach? You told me the approach for you want to give salvage chemo. What salvage? Let's say ice. You gave R ice because it's DLBCL.
Yes,
It has gone into CR. Now, what do you want to do?
Either I can go ahead with the allogenic transplant, or if CAR T cell.
Sorry? Allogenic.
Or
You do allogenic for DLBCL?
no, sir. Sorry.
Autologous transplant or CAR T? What will you prefer? Who do you want to give CAR T? Who do you want to give autologous transplant? So when you have a primary refractory less than 1 year, patient is progressive. These patients after autologous also will fail. So the point I wanted to teach here was
So your voice is
to tell you was in Hodgkin lymphoma, primary progressive or early relapse, still there is a chance with autologous transplant you may be able to cure the patient. Whereas if it's a DLBCL and the patient has either primary progressive disease or progressing within a year, your autologous transplant rates are very, very poor. So if at all, you may have to take the patient for a CAR T after salvage. Maybe with some minimal disease, you can take the patient for CAR T. And then later you may have to salvage him at a later date with autologous transplant or bites. Okay. So Rofitamab or something like that. So the approach at that point will divide between Hodgkin and DLBCL. Okay. Yeah, good. You did well. I mean, any other comments from Armugam sir and Prabhakar sir? Yeah, thank you. Thank you so much.
Yes. Armu sir, do you want to?
Yes, sir. You are doing what investigations you are doing before starting ABVD in your center? Means for bleomycin toxicity assessment, DLCO or PFT?
Sir, if there is any patient is having any risk factors only, we are routinely doing PFT and DLCO, sir. Otherwise,
even you are not doing PFT upfront. If the patient is having a chronic,
if the patient is having any pre-existing comorbidity, like COPD or anything, we will do, sir. Young patients, otherwise, routine PFT.
You are not doing.
Not.
No. Okay, in between ABVD regimen, so the patient is presented with neutropenia. Okay, what is your management? Are you reducing the dose? Are you going to give the GCSF support, or you are continuing the same regimen without any interruption?
Sir, we'll continue the same regimen, sir, because dose we need to maintain the dose intensity, and also there is toxicity if we give GCSF with bleomycin. Increased risk of pulmonary toxicity.
Yeah, good. Then what is the follow-up? How you are follow these patients in the?
Sir, after completion of treatment and PET negative, we'll do the clinical examination. We'll review the patient every 3 monthly for the first 2 years, and then every 6 monthly for the next 1 year. And during the follow-up, we'll do clinical examination. And routinely, if the patient is symptomatic only, we are doing any imaging investigation, sir.
Any lab investigation?
Sir, ESR and LDH. ESR, if it is elevated initially, we will repeat, sir.
Okay. So is there any follow-up PET CT is needed?
Sir, no, sir, we are not doing, sir. It's not needed,
Not
sir.
routinely done.
Not-
Yeah, okay. Okay, sir. Prabhas, sir.
Okay, sir. Okay. Is that so? We can wind up.
Yes, sir.
Okay. Thank you, Dr. Arumugam, sir. Thank you, Krishnatram, sir. Thank you, Priyanka.
Yes.
You did
Thank you, sir.
reasonably well.
You being the challenge.